My name is Furqan Moin. I'm a neonatologist, and I have been practicing neonatology for almost last 25 years in America. I have been a faculty member of Aga Khan University Hospital also from 2002 to 2004, and but also in neonatology. So, so basically today we're going to talk about the respiratory distress. Uh, so this is one of the most common problem in newborns when they are born, that they can have some respiratory issues. They can go into respiratory distress. So if you're working in a pediatric or neonatology or a neonatal ICU, then you will see a lot. This problem may occur in babies who are born at term, and especially in the babies who are born preterm. First of all, we need to understand uh, that how the babies basically present with the respiratory distress. So the first thing, that the baby's respiratory rate is higher than in bigger children or in adults. So in adults, basically, probably you guys know that the respiratory rate is around 15 to 20, maybe 25. But in babies, even in term babies, the respiratory rate, normal respiratory rate, is between 40 to 60. So these babies breathe at a higher rate, and they may be completely fine. They may not be any respiratory distress, but they will breathe with a higher rate. All right. So this is the first thing we need to understand. During the sleep, sometimes the baby's respiratory rate may go down to like 20, and that can be completely normal also. There is another thing I want to mention, that there's something called so the periodic breathing is actually normal in in newborn babies. What is periodic breathing? Basically, so sometimes you may have seen it, that the babies, after they're in the first month, they can breathe at a rapid rate, and then they will have a pause, like maybe for 5, 6, sometimes even 7, 8 seconds. It should not be more than 10 seconds. More than 10 seconds mean that the baby probably has problem with the apnea. But if it is 5 or 6 seconds pause, and then they will start breathing again with a higher respiratory rate, and they can do it actually multiple times. So this is something called periodic breathing. That basically reflects immaturity of the respiratory center in the brain, but that is completely normal for babies who are born at term, even in premature babies. So this is a little video. I want to uh, so this so this is a baby who is in respiratory distress. So you can see this baby, that the baby is making a little sound. The baby is breathing fast. You can see some subcostal retractions over there, a little bit of intracostal retractions also, definitely nasal flaring, and this grunting sound, the baby is making. So this is basically the respiratory distress. Um, and this is a very common problem in babies. We see it like multiple times. And it doesn't matter that what exactly the reason of the respiratory distress is. Uh, the babies, with different reasons, basically they can present, with this kind of symptoms, the retractions, the grunting, the nasal flaring, sometimes even cyanotic. This baby, I think, have a little bit of cyanosis also around the lips, if you see closely. So this is basically the babies, how they present with the respiratory distress. And the cause of the respiratory distress, basically you have to do more investigation and then find out why the baby is having this respiratory distress. Uh, so I'm going to talk a little bit about that. What is so in order to understand really that why the baby is having respiratory distress after the baby is born, I think we need to understand that what was actually happening with this baby when the baby was not born. So when the baby was inside the mom, all right, in the uterus. So we need to understand a little bit about. So this is the diagram basically, which is showing the fetal circulation. All right. So you can see that the fetus is attached with the placenta. through this kind of a big artery, which is called umbilical vein, and there are two actually blood vessels which are wrapped around this umbilical vein. These are umbilical arteries, and these basically are supplying blood to the heart, and the heart is pumping blood to different parts of the body. So organ of gas exchange in the baby before birth is not the lung, it is actually placenta. So placenta is doing all the gas exchange, providing the oxygen, removing the carbon dioxide for the baby. The baby filled with the fluid, all right? They are in the developing phase, when the baby is inside the mom, and they are filled with the fluid. The blood does not flow that much towards the lungs. Only 10% of the cardiac output flows towards the lungs, which is basically just to meet the metabolic need of the lung. But there is no gas exchange taking place inside the lung. All the gas exchange is taking place by the placenta, right? So the lungs are filled with the fluid. So in this way, we will understand the problem also which can happen after that. So this is a little diagram of the fetal lung on the left side, and the baby's lung after the baby is born. So you can see that the fetal lung on the left side is filled with the fluid, and the baby's lung after the baby is born, basically the air is entering into the alveoli, and the water is basically getting absorbed. And you can see a little bit, more that there are some ions basically which are secreted from the blood into the alveoli, the chloride ions and the sodium ions, and that basically is responsible for the net movement of the flowing from the blood into the alveolus. And after the birth, basically the movement of these ions, the sodium and the chloride, basically reverses. So it starts moving from the alveolus into the blood, and that is basically all the fluid movement from the alveolus into the blood. So this is very, very important to understand that the lung is filled with the fluid when the baby is inside the mom, and it kind of the fluid start getting absorbed, and then the alveolus basically is filled with the air. So the first problem we will discuss is something called transient tachypnea of newborn. This is a very common problem. A lot of babies come, with this problem to the neonatal ICU. And fortunately, this is a kind of a benign problem. Most of the babies do get better when they have this problem. So what is the problem? It is the retained lung fluid. So remember, the alveolus are filled with the fluid before the baby is born. After the baby is born, this fluid should get absorbed, but sometimes this fluid does not get absorbed completely. There is some fluid which is kind of the lung retain it for some reason, and that is basically called retained lung fluid, or the problem is called transient tachypnea of newborn. So retained lung fluid. So transient means, definitely we all know it's short-lived. So most of these babies basically they improve in 48 hours. Sometimes it can go to 72 hours also. And tachypnea, we all know that it means rapid breathing. So as the name says, transient tachypnea of newborn. So we'll look into the chest X-ray of transient tachypnea of newborn. So as we all know probably that when in the X-ray, basically when the air is entering into the lungs, it will look black. When there is no air entry and when there is fluid, it will look white. So you can see this kind of the lung fields are kind of white out. All right, so this is basically because of the retained fluid into the lungs. And there is something called fluid in the fissure. You can probably see over here. This is the horizontal fissure of the right lung. So as we know that there are two fissures on the right lung, the horizontal fissure and the oblique fissure, and the left lung contains only one horizontal fissure. So you will see most of the time in the X-ray that there is some retained fluid in the horizontal fissure of the right lung. This is kind of pathognomic. So if you will see an X-ray like this, the answer will be that this is transient tachypnea of newborn. And what usually, the transient tachypnea of newborn basically, usually it happens in babies who are a little bit of preterm, but it is the most common cause of respiratory distress in term babies. But as a general, it is a little bit more common in preterm babies. The baby, especially if labor has not already started. So what happened that when the baby is inside and the mom goes into the labor and the uterus is basically contracting, that basically exert pressure on the baby's lungs, and that helps the fluid actually to come out because of that pressure from the baby's mouth. If for some reason the mom does not go into the labor, there was no uterine contraction, then there is a higher chance that this baby may retain this lung fluid. So if there is a repeat C-section, the mom did not go into labor, there is a higher chance that the baby can have TTN problem. Born to mother with diabetes, there is an association with diabetes. Twin babies, so again, because there are multiple babies, so probably the uterine contractions were not exerted that much as it can be for a singleton baby. So that is the reason in twin babies, the TTN incidence is higher. Male gender, again, this is an association that in male babies, they have more incidence of TTN. What we do for these babies, so usually, as I said before, that these babies improve with time. The only thing you have to do, just supportive care, all right? So if this baby is hypoxic, may need some oxygen via nasal cannula, or maybe, with the CPAP, and that baby, basically, you just have to prevent, the hypoxia and make sure the baby is removing the carbon dioxide. So that is basically what we have to. Very rarely these babies, may have so much fluid into the lung that they may require mechanical ventilation. So we may have to intubate these babies and put them on the mechanical ventilator, but this is very rare. Most of the time, these babies improve either, just with the oxygen or maybe CPAP. Usually 48 hours, sometimes 72 hours, and after that they will get better. If the baby is taking longer than that, then we may have to think about other reasons, other causes of respiratory distress. Now, the other problem, which is other common problem which can happen, it is more common actually in babies who are born preterm. All right, so not in the term babies, but preterm babies, it is more common. Sometimes it can happen in term babies also, but it is not that common. So respiratory distress syndrome or hyaline membrane disease occurs because of surfactant deficiency. And we'll talk about the surfactant in more detail later on. It is more common in premature babies. What surfactant decreases the surface tension at the alveolar level. And again, we will talk in more detail. So you guys need to understand really this concept that what exactly the surface tension is and what the surfactant does. And without surfactant, the alveolar. So now we're going to talk about that what exactly the surface tension is. So basically the surface tension is, as the name says, it is on the surface of a liquid. For example, if this is water. So probably that, some of the insects which lives in water, basically they can crawl on the surface of the water. So it looks like there is basically a little thin film on the surface of water, and they can actually crawl on it. So what happened, like why, so that is basically something called surface tension. So what is happening that the liquid molecules, basically, they have kind of a force among themselves, the intermolecular attraction. So if you see this diagram in the middle, this liquid molecule basically is attracted from every side, all right, from above, from below, from right and left, because there are molecules on every side. On the surface, basically, there is no molecule above here, basically. There is no liquid above it. There is liquid below it, there is liquids on the right and the left. So since there is no attraction above the molecule, these molecules basically exert more force on the right and the left. So these molecules basically comes closer to each other. And then basically when they are close, they form like kind of a thin film. And that is basically called surface tension, all right, because of the intermolecular distance basically goes down because of this attraction, and that causes the thin film, and that is the reason those insects basically crawl on the water because of this surface tension. And because of this tension, basically the water, when it is raining, it falls down in droplets, because again that surface molecules basically, because since they're so close, they kind of make like kind of a sphere, and that the reason basically they are droplets. So because of surface tension, the droplets basically are formed. So why, this surface tension, what happens in the alveoli? So this picture, basically, I'm showing it to you that, so basically what happened when the water is absorbed from the alveoli, so a small amount of water basically remains in the alveoli, just close to the epithelial cells of the alveoli. All right. And the reason is because if all the water is absorbed, then these epithelial cells will get really dry, and that can become a problem. So a small thin film of water basically remains above the epithelial cells. So that film of water basically creates a surface tension. All right, and and that surface tension basically, if it is there, then it can actually collapse the alveoli, and we will see, why this happened. So in the next picture, you can see, so on the left side, basically, you are seeing a small alveolus, probably in the expiratory phase, when the alveolus size is small. So these water molecules, basically they're lining the alveolar lining, actually comes close together. And this intermolecular attraction goes higher. And because of this intermolecular attraction, the alveoli basically will try to collapse even more. All right. And that becomes a problem because your alveoli is collapsing, and it will become very hard for the baby to inflate a collapsed alveoli. Just think about a balloon. If the balloon is completely collapsed, then what will happen that, you have to exert a lot of force to inflate that balloon. All right. So the same thing will happen with the alveoli. If the baby has to create a lot of negative pressure to inflate that collapsed alveoli. On the right side, this alveolus is well inflated, probably in the respiratory phase. So the molecules, the water molecules, are far away. There is not that much of intermolecular attraction, and there is not that much of surface tension. So surface tension is kind of dependent on the radius of that of the alveolus. If the radius is small, there is more surface tension. If the radius is big, there is less surface tension. So when, if there is no surfactant, then what will happen that whenever we breathe out, our alveoli, the radius gets smaller, and the alveoli will become, will collapse basically. So what the nature has done to take care of this problem, so we will see in the next slide. So this is something called surfactant. So surfactant is basically surface acting agent. So that is basically what it does, and that is why it is called surfactant. So this is a little diagram of common surfactant. So surfactant is like soap is also surfactant. Any detergent, the laundry detergent, they are also surfactant. So they basically take care of whatever the oil drops are in there, and they will clean it. But just to understand this, the surfactant contains a head and a tail. The head is basically hydrophilic, and the tail is hydrophobic. All right, and and what it does in the alveoli, so we will see in the next slide. So you can see over here, these are the same surfactant molecules. The head is over here, and the tail is here, uh, and this is basically lining that water, the fluid film, which is basically on the alveolar epithelial cells. All right, so this is basically covering that water surface. All right, and that is the reason it basically decreases the surface tension. These head basically will goes into those water molecules and decreases the intermolecular attraction basically between those water molecules, and it will decrease the surface tension. So in the normal alveoli, the surface tension is almost negligible because of this surfactant layer. It's a little bit more explanation over here that this surfactant is produced by the type 2 pneumocytes, which are, a type of alveolar epithelial cells. These are basically secreted by the endoplasmic reticulum and the Golgi apparatus, and then they are stored in those lamellar body. These are basically globules of surfactant, and then it is excreted actually from those epithelial cells in a spatial structure, what is called tubular myelin. All right, and that tubular myelin basically will go and line this the fluid layer which is above the epithelial cells, and decrease the surface tension. All right, so this is very important that the surfactant basically decreases the surface tension, and without the surfactant, the alveoli basically will collapse. This is an X-ray of the baby with the respiratory distress syndrome. So you can see that there are small kind of it's more like a granular appearance, right? There are small whitish granules, all over the chest. So what these granules are, basically these are collapsed alveoli because the air is not entering, because the alveoli is collapsed, and when the air will not enter, basically it will look kind of white. All right. So, but these are kind of a granular appearance. So whenever you see this kind of an X-ray, which is kind of granular, so that means that this is respiratory distress syndrome or surfactant deficiency. If you remember the X-ray we have seen in TTN, it is not granular. It's not like generalized kind of whiteout, but this is a bit granular. So granular means that your alveoli is basically kind of collapsed, and that individual alveoli is looking like kind of a granule in the X-ray. What we do, for babies with the surfactant deficiency or respiratory distress syndrome, that we put them mostly on the CPAP. So what the CPAP does, with when the babies have RDS, so the CPAP basically creates a pressure when the baby is in the expiratory phase. So it does not allow the expiratory phase to complete. All right. So in other words, that the baby retains some air in the alveoli. So there is some air trapping basically which happens when the babies are on CPAP. So the air trapping basically helps in keeping those alveoli open. All right. The same thing what the surfactant was doing, keeping the alveoli open, preventing the alveolar collapse. The same thing the CPAP will do. It will prevent the alveolar collapse, and when the alveoli are not collapsing, the radius is still kind of big. So remember that if the radius is big, then the surface tension will be low. All right. So even if the baby has surfactant deficiency, the CPAP may help in preventing the lung collapse and actually reducing the surface tension also. So this is very, very actually helpful for these babies with the RDS. Most of the babies we take care, we just put these babies on the CPAP, and give them time. Usually the babies start producing the surfactant maybe 2 or 3 days, and then usually we are able to stop the CPAP, and the babies are usually do pretty good. So this is one of the most safest way of dealing with this problem, the RDS. The next thing, this is surfactant. Actually, we can give the surfactant from outside, but we have to intubate these babies. We have to pass a breathing tube and then give this surfactant. And this surfactant will basically go inside the alveoli, will line those basically the fluid layer, and will decrease the surface tension. I'm not sure whether this surfactant is available in Pakistan right now, but when I was there in Aga Khan, actually we used to get surfactant from Canada, and then we used to give it like on very selective basis to babies who really needs it. It's easily available over here, so we use it more generously and more independently. Over here, there are different types of surfactant, but I think I'm not going to go into that much detail. The last thing, which I want to do to take care of these babies is to put them on the ventilator. Sometimes, if the baby like this, if it's very small and cannot breathe on its own, even if you have put them on the CPAP, the baby lungs are, so stiff that the baby is not able to breathe, then we may have to put these babies on the ventilator, and then kind of keep them on the ventilator. So the ventilator, what it does basically, that it gives a little bit of positive inspiratory pressure also. So so it helps the baby actively in inflating those lungs. But the problem with the ventilator, that it's kind of hit the lungs, with that positive pressure. And then sometimes the lungs can get overstretched also. So that causes basically something called barotrauma and the volutrauma to these babies, and that can lead to actually chronic lung disease later on. So this is something, again, we like to avoid because of the risk of mechanical ventilation. But some babies may need it, and if they need it, we have to give it to them. But we like to extubate these babies as soon as possible back on CPAP as soon as they are stable enough. So the next problem I want to discuss is the Meconium aspiration syndrome. So this is also a problem which usually happens in term babies, not that common in preterm babies. Actually, it's more common in post-term babies. So any baby after 40 weeks, basically, we see that they can pass the meconium. So what is meconium? It is basically the baby's stool when the baby is inside the mom. Some of these babies, basically, they may pass this meconium even before delivery. So what will happen that when the baby is inside the mom and the baby has passed the meconium, it will get mixed in the amniotic fluid, and the amniotic will get stained with that meconium, and then baby will basically swallow that amniotic fluid, will also aspirate it, which will go into the lungs. And because meconium is not supposed to be there, it's like a foreign body, so it can cause a lot of problem. It can cause obstruction of the airways. It can cause inflammation of the alveoli, and these babies actually can get pretty sick. So most of these babies actually, so depending how much meconium they have aspirated, if they have aspirated too much meconium, then these babies has to go on the ventilator. If not that much, then sometime we may have keep these babies on the CPAP, sometimes even a little bit of oxygen, but really depends on the actually it depends on the amount of the oxygen and the consistency of the meconium. So amount of meconium and consistency of the meconium. If the consistency is thick, then it can cause more problems. So this is a picture of a baby who has passed meconium, and you can see, it's kind of greenish. So the baby is still in the mom. Actually, the amniotic membrane is still intact, and the baby already has passed the meconium. This is the X-ray of the baby with the meconium aspiration. So the message to be taken over here is basically these babies have kind of fluffy infiltrates in the lung field. So like soft fluffy infiltrates you can see over here. So these are basically all meconium in the airway and in the alveolus. So this will look like kind of a fluffy infiltration. It's not like generalized. In some portions you will see more infiltrates, kind of soft infiltrates. So this is, kind of pathognomic for meconium. This baby is already intubated. You can see the breathing tube in there. This baby look like, have severe meconium aspiration syndrome. This baby will be on the ventilator for a long time because of a lot of meconium in the lungs. But usually babies have a good prognosis. They may take like a week, maybe sometime even 2 weeks, but usually once the meconium is reabsorbed, then these babies do pretty good. So now the next topic is neonatal pneumonia. It is actually not that common problem in America over here. I haven't seen a baby with a neonatal pneumonia for a long time. And the reason is because, a lot of things basically our OBGYN basically does to take care of this problem. So they start treating these moms basically with the antibiotics and take care of the infection in the mom so it does not transfer into the baby. Right, so that is the reason the incidence has gone down over here. But I think in the developing countries, it is still a common problem. And so in the developing countries, basically you can divide it in the early onset pneumonia and the late onset. The early onset is within first week, and the late onset is after the first week. In the first week of life, the gram-negative bacteria like E. coli, Klebsiella, they are the most common. And after the first week, the gram-positives, they are most common. But in America, if you get this question like in USMLE or something, it is GBS or Group B strep. That is the most common cause of neonatal pneumonia in the neonatal period. But again, it's not that common anymore. But if you get this question in the USMLE, it is Group B strep. There is something called intrauterine pneumonia also, which can be considered a subgroup of early onset disease. These babies basically develop pneumonia inside the mom. So and the babies, they are not able to localize their infection. So if there is pneumonia, it will go into the blood. The baby will have septicemia for sure. So these babies will born, maybe stillbirth, maybe with very low Apgar scores, severe respiratory distress, and usually the moms has chorioamnionitis, which is infection of the chorion and the amnion, the fetal membranes. So these babies basically they come out very, very sick. I mean, we don't see this fortunately that often, but these babies, they will have a lot of problem, a lot of respiratory distress, very hard to manage. They will be like in shock, hypotensive, poorly perfused, and you have to start the antibiotics, fluid resuscitation, everything. They may have to go into DIC, disseminated intravascular coagulation. You may have to give the FFPs. So lots of, but even if you do everything, it has kind of a high mortality. So this is the typical X-ray for the neonatal pneumonia. So look, it look more like RDS or TTN, kind of a mixed X-ray. So the X-ray is not like typical of pneumonia. So it look like kind of just generalized kind of white out X-ray, more look like kind of RDS kind of an X-ray. So the way you kind of diagnose that this baby probably have an infection or pneumonia or septicemia is by the generalized symptoms. That if the baby looks shocky, the baby is hypotensive, the baby is poorly perfused, baby look extremely sick. So that cannot be explained by just a lung pathology like TTN or RDS. So that's how you kind of differentiate, with the generalized sign and symptoms, the neonatal pneumonia or septicemia, and then you have to start the antibiotics right away because this baby can get extremely sick very quickly. Now I'm going to discuss a little bit about the surgical problems also. So there is something called congenital diaphragmatic hernia. All right, this is again not a very common problem, but if this problem happens, there is kind of an emergency. All right, most of the time we know about this problem because our OB/GYN, they can do the antenatal ultrasound. They usually tell us that we are getting this baby, and usually we have a whole team basically for this baby, and we attend the delivery basically. The attendings and the nurse practitioner, they are all there and taking care of this baby because this baby can get pretty sick very quickly. So what is congenital diaphragmatic hernia? See, we know that our diaphragm basically separates our abdomen and the chest. All right, so diaphragm is like a curtain between the abdomen and the chest. So if there is a defect in this diaphragm, basically, so what can happen that the stomach, the intestine, or the liver actually can migrate into the chest, and then they basically impact with the growth of the lungs, and even the blood vessels in the lungs. Basically, they can impact the growth. So these babies can have a lot of problems. So this is a little diagram of the congenital diaphragmatic hernia. On the left side, you can see that's a normal diaphragm. It is separating the abdominal cavity with the chest. And on the right side, there is a baby with the diaphragmatic defect. On the right side, the diaphragm you can see is kind of missing, and basically your liver has gone up, your intestine has gone up into the chest, and the chest basically, the lungs basically will not develop. And it's not like the lungs are just collapsed, but they won't develop. So there's something called pulmonary hypoplasia. So what is pulmonary hypoplasia? Like if in a certain like surface area, there should be that many alveoli, right? For example, in that surface, there should be like 50,000 alveoli. But because of this abnormal growth, instead of 50,000, you have only 5,000 alveoli. So that becomes, because you have less alveoli, so that is pulmonary hypoplasia. All right. So this problem actually can lead to pulmonary hypoplasia. And that is the reason, these babies can get pretty sick. This is one of the baby, the X-ray with the diaphragmatic hernia. You can see on the left side, it's all these bowel loops, basically, which has air in it. They have ascended on the left side, and your heart is shifted on the right side. Your right lung basically is very small. The heart is shifted on the right side. And because of this, even your right lung can be hypoplastic also because of all the pressure which was there for some time. So the right lung may also not develop. So these babies can get pretty sick. So the management of this problem basically is that you have to stabilize this baby initially. You don't go for the surgery right away. So at least 2 or 3 days, you make sure that the baby is stable, can tolerate the surgery. And then, this baby will go for the surgery and they have to reduce all this bowel. And then even then after the surgery, these babies may be on the ventilator for a long time because again, this is pulmonary hypoplasia, not just the atelectasis of the lungs. So this is kind of a long-term problem, needs long-term management. The other problem, which is also not very uncommon, there is something called congenital cystic adenomatoid malformation. It is called CCAM or CPAM. So CPAM is congenital pulmonary airway malformation. So it can happen in the alveoli or in the airways. That is why it is also called CPAM. It's a benign lung lesion that appears before birth as a cyst or mass in the chest. And it is made of abnormal lung tissue that does not function properly. So basically, it's more like, the normal lung tissue is replaced by a cyst. And this cyst is not functioning. It does not participate in the gas exchange. So basically, again, you will have pulmonary hypoplasia and also the mass effect. because of this cyst, that your heart will be shifted, the other lung will be shifted also, and that can cause problems. So again, you are dealing with pulmonary hyperplasia and the mass effect because of this cyst. The cyst can be macrocystic, and the microcystic, again, if it's big, is macrocystic. If it is small, it is microcystic. So this is the baby with the big kind of macrocystic cecam. You can see on the left side, it's a big mass. This is not a functional mass. It is not communicated, like with the lung. It is not doing any gas exchange, and it can cause a lot of pressure. So the left lung most likely will not be developed adequately. It's causing a lot of pressure. The heart shift on the right side in the right lung will also not develop. So again, it's a mass effect and the pulmonary hyperplasia. This is a little picture of the chest X-ray and the CT scan of a baby with the CCAM. So you can see on the right side, you can see, if you look it closely, you can see a small cyst on the right side of the lung. So that is basically, multiple cysts are in there. This is the CT scan of the same baby, and you can see, like, a lot of cysts. So this one will have kind of a poor prognosis because there's a lot of cysts. Almost the right lung is almost completely replaced by the CCAM, and the left lung is also affected with that. The heart is shifted on the left side, and the left lung is also kind of small. A little bit about the pulmonary sequestration also. So the pulmonary sequestration, basically, it is also like, you can compare it with the CCAM, but instead of the cyst, it's the accessory lung. So there is a lung tissue basically in there. In the CCAM, there is no lung tissue, just a cyst. In the pulmonary sequestration, there is an accessory lung. So there are lung tissues, but the problem is these lung tissues are not connected normally with the pulmonary blood vessels. So there is no gas exchange taking place because they are not connected with the blood, because blood has to flow towards the alveoli for the gas exchange. So these basically are not connected with the normal blood vessels. And there can be intralobar sequestration, there can be extralobar sequestration. Extralobar basically is outside the pulmonary lobes, and there is another type, extralobar subdiaphragmatic, which is actually below the diaphragm. All right, intralobar is basically inside the pulmonary lobe. So that's how you kind of differentiate it. So the extralobar sequestration is usually bigger in size. It causes more, again, the pulmonary hyperplasia because of the mass effect, and the babies can go into respiratory distress, cyanosis, even infection. Whereas intralobar usually present in the late childhood or adolescent with the recurrent pulmonary infection, because usually the intralobar is smaller in size, so does not cause that much of a problem, and most of the time it is diagnosed later on. This is a little diagram of the pulmonary sequestration. So you can see the intralobar sequestration on the left side. So it is confined to the lower lobe of the right lung. And then on my right side, basically, you can see the extralobar sequestration. So it is outside the lobe, and then also subdiaphragmatic. So that is below the diaphragm. This is a little picture of the chest X-ray of pulmonary sequestration. So the interesting thing in this one, that you usually see kind of a triangular opacity, kind of a wedge-shaped opacity. So if you see something like this in the chest X-ray, then it can be pulmonary sequestration. But definitely you have to do a CT scan of the chest to diagnose it, to confirm your diagnosis. And then I'm going to talk a little bit about the bronchogenic cyst. So these are not very common, but as the name said, that these are in the bronchi. So these are in the airways. These are not in the alveoli. All right. So these are congenital membranes of congenital malformations of the bronchial tree. Because these are in the airways, so they are in the mediastinum. So they are the mediastinal mass that can enlarge and can cause compression. So that can actually cause airway obstruction. All right. And it is also considered the commonest foregut duplication cyst. So as you guys probably know, that your airways and the lungs, basically, they are derived from the foregut. So that is why it is called foregut duplication cyst. All right. So in many instances, the bronchogenic cysts are asymptomatic. So depending on the size, and are found incidentally when the chest is remade. So, these babies or even kids or maybe adults, they can be completely asymptomatic. And for some reason, if somebody do an X-ray on them, then they will find this bronchogenic cyst. So, but if you have a large cyst, then it can cause bronchial obstruction, leading to air trapping and respiratory distress. And sometimes these cysts can get infected also. So again, the size of the cyst is basically important. I am actually following a baby who's not born yet with my OB physician, and most likely this baby has a bronchogenic cyst, and it is already causing a unilateral obstruction of one of the bronchi. But the other bronchi is okay, but there is some mass effect also. So we will be definitely taking care of this baby. We'll see. If the baby, has some obstruction of the airway, usually the babies will make some sound during breathing, something called a stridor. So that sound basically usually makes either respiratory stridor or expiratory stridor when the airways are involved. So we'll see how this baby will do. This is a little X-ray of a baby who has this bronchogenic cyst. So you can see that it is in the mediastinum. All right, so it is in the bronchi, and this is kind of a big cyst, and I think this probably will cause some airway obstruction, and this baby may develop with some respiratory distress, probably some stridor also. Sometimes even with the wheezing, if it's a little bit low. So this baby most likely will be should be symptomatic. So that is basically it. And thank you very much for listening to my presentation. And again, I will be willing to do more presentations if needed, mostly about the newborns. And thanks again.